Hi everyone. Hope you're doing all right there in general practice world. And as you can see, I'm here solo whilst we just settle in and figure out what we're going to do in today's live stream. Don't worry, we've got plenty of content for you. In fact, I've got about 5 things to talk to you about. Andy is hopefully on his way. He's been held up en route, and hence why you've just got me for the start. But I'm going to give you a little minute just to settle down, and then we're going to get cracking with this crazy lineup of information, including the Leng review and the review of the Leng review, shall we say, in terms of what we're going to cover in today's episode. So I hope you're all settled for what's going looking like to be an interesting episode as well. In addition, we've got a few extra stories we're going to cover, but I'd love to know what you guys are doing right now. I've got about 10, 15 of you joining us currently. So I'd love to know what you're up to, whether you are similar to others, just getting settled down for the evening, or whether you are planning something else, or what you've got planned, really. So let me know in the chat down below. And I think on that note, I'm going to get us started as we talk about the Leng review. Shall we get cracking? The Leng review is out, and we're going to be talking about what this implication is for general practice in terms of primary care and other parts of the healthcare system of this significant review and the future of a particular workforce, as well as some extra news stories, including the fact we've got a new RCGP chair, as well as various other stories around what the GPC is up to and what that may mean for you out there in general practice as we, as ever, tech enhance your primary care and learning. Hello, EGP learners. Welcome to this episode where we're talking about various different aspects in updating you on what's been happening in general practice, including the Leng review and some news stories that have been happening over the past week or so in general practice. As you can see, I am solo at the moment. This is because Andy is on his way back from work and unfortunately been held up as a result of it, and hopefully will be joining us. But up until then, you don't worry, you've got me, and we're going to be going through various different aspects and stuff. I would love it if you're watching us live, if you could give me a shout out to let me know that you're out there as well. I can see there's about 15 of you joining us live at the moment. Definitely a difference compared to my earlier live stream done yesterday with TPP talking about auto review, where we had over 300 people joining us live. Definitely feel that's a better time slot than this one, but don't worry, got lots of stuff that we're going to be looking at for you to try and keep you updated in terms of what is happening in general practice. So just to cover what we are covering, so in this episode, the first thing we're going to do is take a look at the Leng review. So this is the review looking at physicians associates in general practice and the NHS as well as anaesthetic associate. We're going to not really focus that much on that because it's less relevant for general practice. After that, we're going to give you some news updates in terms of other things that's been happening in general practice, including stuff with the RCGP, the GPC, and other news stories, including stuff Wes Streeting's been up to as well over this episode. Hopefully in that time, Andy's going to join us as well. But let's get started, shall we, as we talk about the Leng review. And in order to do that, I'm going to bring it up for you. So let's go to this, and you should now all see it on screen. So this is the PDF of the document available online if you want to have a look at it. And as a result of that, you'll then have this lovely 134-page document. It's not as big as the 10-year plan that myself and Andy covered last weekend. And obviously that was live at Andy's studio. It was amazing. We had over 100 of you joining us live for that particular episode. But this one is fairly meaty, 134 pages, as I said. Although when you come into the appendices and all the kind of stuff, it's actually just over 100 pages in total. And as you can see, it's got some really interesting content that it talks about what comes up in the document. We're going to talk about some of the figures and stuff, and we'll go through the executive summary. And then we are going to jump around a little bit just to talk about some of the document stuff that comes through, including the recommendations, which is the key part that I know many people are interested in. As I said, I'm not going to focus as much on the anaesthetics associates recommendations and stuff that come through because that's less relevant for those of us in general practice, but they are also very similar to the physician associates one. And then talk through a couple of things that may help you understand what to do moving forward, particularly if you are looking at how physician associates will be moving forward. Obviously, I've not come to the big thing that's about this new role, about the role and stuff yet, but we will come to that shortly. It does talk about tables and figures, and it's got a list of them throughout. They're actually pretty decent, some of them, and we're going to look at a couple of them as well, as well as the tables from there. So there's a forward from the chair. I'm going to skip over that because I'm going to move straight to the executive summary and talk about what it's mentioned. Now, it does talk about the fact that PAs have been prevalent in the NHS since the early 2000s, and that as a result of that, it has continued to develop as a role within general practice, obviously massively supercharged in primary care because of the R's roles, in particular in year 3, I think it was, when they became online from then, and then subsequently have increased and then changed as a result of that post-COVID. It then talks about how the expansion of numbers has happened, and then obviously there was an increasingly debate since 2004 in terms of the future of the role and the impact it was having, and in particular how this may work with future multidisciplinary teams and aspects, particularly in primary care. Talks about the aims and scope. So the aim was to review and determine whether the roles of PAs and AAs were safe and effective as members of a multidisciplinary team. And then secondary questions were considered in terms of what modifications might be required to improve the confidence of the roles, and whether the rollout in England was supported safe and effective development of their roles as well. So the first question they were asked to look at was, what is it safe? Is it effective? And then if it wasn't quite there, how to improve that, or how to improve that irrespective from there. It talks about gaining evidence, and it's took a review of various different pieces of evidence. We'll talk about the evidence in a second, so I'm going to skip over that particular point. And then it talks about the actual evidence that came through. In particular, in primary care, it talks about the research that was, and it mentions this repeatedly through the document, that the quality of the evidence that's available is limited. And that's probably the best word that it comes up with throughout this document, that it is limited, and that often there was very little difference they could see from some of the roles in how it would work, but also that the quality of that evidence providing that information was limited. Remember that word. It then talks about perspectives. There was a huge amount of focus work done with this particular role, both from patients' perspective, including some of people interviewed throughout. I think it was 23 in total. I think in terms of patients that had experiences, as well as various other focus groups, and then lots of information taken from organisations like the BMA as well. Where are we? And then it talks about the regulatory aspects. So those of you may remember, the long-term plan in particular had a key focus when it came out in 2023 about the use of physicians associates, and key to that they would be included as well. And then it considers all the different factors. I'm going to jump to this part here. So the future of the role of the physicians associates and anaesthetic associates. So at the start of the read, there was no preconceived ideas about the outcome that they were making, and they would carefully consider whether or not to determine and recognizing there was overwhelming evidence to support a complete abolishment of PAs or AA roles, or to continue the roles unchanged. And that's what they were looking at. These questions were considered primarily and taking into account evidence on the safety and effectiveness, but the evidence was, as I keep saying throughout this, limited, and also considering the views of patients, clinicians, and various other things themselves. So they looked at various different things and came up with these recommendations. So I believe there was 17 recommendations in total. Apologies, 18 recommendations in total. I'm going to go through those in a second. So don't worry, we'll cover all that aspects for you. Just before we do, I can see that we've got a guest joining us. So how are we doing there, Andy?
Hi, Gandhi. Sorry I'm a little bit late. Had another engagement this afternoon, which went on a lot longer than was expected. I'll tell you all about it later. Viewers don't need to know.
That's not a problem. So just to catch you up, Andy, so we're talking about the Leng review, an interesting document to get started with and things. And I just mentioned that we are going through the executive summary, talks about some of the evidence that they've demonstrated as a result of it, and was just about to mention the recommendations. And basically, Andy hasn't unfortunately had the opportunity to prep for this because, as he mentioned, he's been running late. But we're going to talk through it, so don't worry. I've had the opportunity to have a good read of this document, and we're going to talk about the various different recommendations that they have made when it comes to the roles in particular. Now, throughout this live stream, I've continued using the term physicians associates, and I guess the key and the first recommendation that has come through from the Leng review is that the name of these roles should be changed. So as you can see here, recommendation 1, the positioning of the role of physician associate should be renamed as physician's assistant, positioning this role as supportive, complementary member of the medical team. So if there's one thing you take from this, it will be just that the name of the role has been changed as a result of the recommendations. And we'll talk about, and I'll show you later what the actions are from this particular review. But this is one of the key ones that's come through. Any instant reactions from that, Andy, in terms of the name change?
I mean, it feels welcome to me. Anything that provides clarity to patients and to everyone involved in interacting with staff about the role that they are doing is sensible. And yeah, I'm still selling myself, Gandhi, but yeah, it sounds sensible. I mean, I don't work with physicians assistants or associates, and haven't done. I know you've spent time working with people in those roles. I guess as someone who's had contact with them, I'm perhaps more interested in how you feel about the change of name.
So interested this came up today, as you can imagine, following the fact that the Leng review came out just yesterday. So a couple of physician associates I work with, I've had a chat with them today. They're clearly not happy with the change in the name. I think they feel it's a weakening of their particular role, but I think they've also accepted that that was a likely outcome of the review. I think disheartened is probably a good word I would use in terms of what they're feeling. I can understand, though, that from a perspective, of a national perspective, that repeatedly it talks about throughout the evidence that it is confusion with what the role means to patients that has been a common thread throughout a lot of the evidence that they did find. So there's that question of how much are practices, how much are the roles of the individuals going to that step to explain what the role is. And how that works. And I think in some places they're probably doing that very, very well. And I think in some places we know that there is evidence where they have not done that very, very well as well. So maybe the fact that it's changing the name, whilst although I can appreciate it may feel, a weakening of the role in some ways to some people, I think it is also a point that does clarify what the role is different and how it is different to the more traditional medical roles that exist. Yeah.
Yeah, I mean that makes sense to me. I mean, it must be quite confusing for people who have trained to do a certain role, be faced with controversy in that role, and have the name change. So I could understand and see how that would be really, really frustrating and disheartening to people in these roles. It's they're in a difficult position and subject to a lot of scrutiny and a whole report about their role. So it must be quite demoralizing.
Well, there are some further changes as well. So I think it's probably worth we go through those in addition to the name change. So next one is recommendation, which is talked about credentialing. So that physician associates should have the opportunity for ongoing training and development in context of their formal certification credentialing program. This should include the ability to take added responsibilities that are commensurate with their training, including the potential to prescribe and order non-ionizing radiation. So, although we talked about some, and we're going to talk more about the scope of practice in a little bit later, one of the things this does set up is that there is potentially the perspective for this role to expand and grow in the future. And that's further supported by the next recommendation, which is career development, that talks about that physician associates should have the option to become advanced physicians associates. And this would be one step above in the Gender for Change rankings or banding, sorry, in terms of the job profiling and that kind of thing. So these two basically focus on the development of the people within these roles, and sets out a clear path, I think, or a clearer path than I think we've had previously. Thoughts, Andy?
Yeah, I agree. It's quite helpful and quite supportive of the role and the value that it can bring. Highlighting that we would like people in these roles to take on career development and perform further functions such as the ordering of non-ionizing radiation-based tests, for example. So that's it. That sounds very sensible.
I think the interesting part you mentioned prescribing, which obviously has been a part where many clinicians have felt that physicians assistants, it's a harder area to look at because prescribing is considerably more complex than some of the other aspects that come into play.
It depends on
but
the
it
course,
doesn't shy
doesn't
away
it?
from it.
Yeah, it depends on the course that's done to give them that function and the credentials to do it, and provided that is robust enough, and that's a very big question, then that may satisfy people who feel uncomfortable with it. There are other non-medical positions in general practice and in medicine who do prescribe following completion of appropriate courses. So is it that much different?
I think it comes down to the training that comes into play, and I guess the support as well that is there and evident and stuff. But there's still more. So recommendation 4 is talking about undifferentiated patients, that physicians' assistants should not see undifferentiated patients except within clearly defined national clinical protocols. So I was trying to have a look at these national clinical protocols, and it mainly makes reference to the RCGP guidance and the Royal College of Anaesthetists guidance in terms of structures and kind of things that exist. So this is some EGP listeners probably remember the episode we did where we looked at the RCGP guidance from about 9-10 months ago, I want to say it was. And we'll try and link that episode towards the end of this one so you can recap yourself on that. But effectively, this talks about not seeing children, for example, not seeing mental health conditions, not seeing undifferentiated aspects and things, and various other things as well. I think I agree with that to some degree. I definitely agree with that for newly qualified physician's assistants. I think for those that have had more extensive training and experience, I think there's probably a little bit more flexibility, and that's one of the interesting things that it doesn't comment. But also, I do agree with the concept of not seeing completely undifferentiated contacts. And I think that's one of the powers potentially of things like total triage that might help with some of that. Any thoughts, Andy?
Again,
I keep putting you on the stop. I just need a breath more than anything else.
Yeah, no, I agree. Sounds really sensible. I mean, recommendation 5, I think, is really interesting. Just moving us forward. So newly qualified physicians associates should gain at least 2 years experience in secondary care prior to taking a role in primary care or a mental health unit. I mean, you've worked with physicians associates already. Is that a big change? Have those that you've worked with had 2 years in secondary care before moving to primary care, or have they come straight to primary care?
So I think that is quite a significant change, because we have had PAs, for example, previously who've joined through the R's roles direct from completing their training and the exposure that they've had into primary care. So I think that will be a bit more of a significant change. I can understand why they put that in. I mean, that's not really that dissimilar from GP trainees, or sorry, not GP, but from resident doctors. They transfer in terms of their F1 and F2, although sometimes some resident doctors can have general practice as a rotation in their F1 and F2 years. But I think it effectively creates a parallel system that is, and a hospital environment is felt to often be more controlled compared to general practice, because obviously the undifferentiated potential of what can happen in general practice, and that anything can walk through the door, compared to the more narrower gaze, generally speaking, of a hospital-based rotation. So I can understand again why they've included this, and I think that will be a significant change that we see. And I guess that potentially also changes the trajectory in terms of the development of these roles, because it, by definition, increases the length of them almost before they see undifferentiated potential contacts in general practice.
Yeah, I think it's good to see a parallel with with medical training and with nursing training as well, with some significant period of time spent in hospital. As you say, it's a more controlled environment in terms of patient flows, and it's probably a more controlled learning environment potentially, and it's very resource intensive, I think, to train people anywhere, but particularly in secondary care. It's extremely resource intensive to train GP registrars, for example. So I think shifting some of their training, and experience gaining into 2 years in hospital sounds really, really sensible. And that really jumped out as me as something that sounded sensible to me. Having been through the training that I've been through, maybe I'm biased that other people should be trained along similar pathways, but that jumped out at me.
Yep. And I guess with that training then comes team working and potentially supervision / oversight, which is what recommendation 6 talks on. So it does mention about the role forming a clear part of the team structure, and in particular with that being a senior clinician lead role, line manager / supervisor, whatever you want to call it, but effectively a named supervisor for each individual physician's assistant moving forward. Now, I think a lot of places probably already have this in place, and if you don't, this is, I think, a necessity, because ideally these roles do need support and stuff in order to make sure they are functioning safely. So I think, this is a recognized recommendation that's going to come through. Then it talks slightly more interesting about identifying roles. So it talks about standardized measures, including national clothing, lanyards, badges, and staff information to use to distinguish physicians' assistants from other roles. I think the uniform one's picked up a little bit of traction in interesting places, because who knows what that uniform should look like. But also, how do you vary that for practice-based work where general practice doesn't really have a uniform either? But
I'm probably taking this as a sort of either or, use something from the list to differentiate physicians' assistants from other staff. I think correctly labeled badges are really, really sensible. I think it's giving options, because I think different environments will probably already use some of these options to differentiate different roles within them. In a hospital, it might be more about clothing and uniform. Certainly in general practice, it may be more about lanyards and badges, and it'll probably be left to individual organizations, provided there is some sort of differentiation. That's how I'm reading it. Although I can see how being told that you need to have a different uniform might be a little bit patronizing and demoralizing for physicians' assistants.
Potentially. It then talks about professional standards, so that there should be a permanent faculty made for physicians associates, and then it talks about physicians assistants and physicians assistants in anesthesia, which is the new name for anesthetic associates. In particular, the Royal College is being involved in that, in particular for the anesthetics, it'd be the Royal College for anaesthetists, and then for the physicians assistants. It doesn't really specify who's going to lead on this, but it's a kind of a challenge thrown out to the Academy of Royal Colleges themselves directly. The next few recommendations are specifically the same thing, but for anesthetic associates, or as they're now called, physicians assistants in anesthetics. Does that make sense, Andy?
It did, I think. Yes. I'm just having to check myself and check you in terms of using the new terminology, but I think we're getting better.
Yeah. So again, just for clarity, we have moved from physicians associates to physicians assistants, and we moved from anesthetics associates to physicians assistants in anesthesia.
Yeah. Yes.
Okay. And then finally, and then finally, it's got some extra recommendations for the system. So the wider system, and that's from recommendation 15 onwards. So regulation accountability, and this is specifically directed to the GMC. So requirements of regulation, reaccreditation, and physician's assistants and physician's assistants in anesthesia within good medical practice should be presented separately to reinforce and clarify the differences from those of doctors. I think that's going to be an interesting one, because obviously there's this concept currently of a register for obviously doctors and a separate register for the physician's assistants. And what does this look like in terms of a potential different register, as well as the guidance itself that exists? Because there's very much been a combined guidance, and I think they're recommending that actually there needs to be a separate one. So it'll be interesting to see whether the GMC does respond to that, and how they respond to that in particular.
Should I take recommendation 16?
Yeah, go for it.
Yeah, supporting doctors as leaders and line managers. Doctors should receive training in line management and leadership, and should be allocated additional time to ensure that they can fulfill their supervisory roles and to assure effective running of the health service. So this again sounds sensible, and I guess it's important that doctors are, if there is increased supervision of physicians assistants, that doctors are paid to do that, or released from their other roles to do that. So I think it's really important that that's included within the recommendations. And then also going along with that is knowing how to line manage and lead this particular type of staff role. So sensible again. Thoughts?
Potentially. I can see there being some pushback on this, in terms of people saying, well, why should I have to become a line manager? I didn't become a doctor to become a line manager.
Yeah, it's interesting actually to see the word line management, because even as a GP partner, whilst we're responsible for staff and probably do a lot of line management roles, actually in terms of kind of pure line management things, sort of managing sickness leave, managing of annual leave, managing of annual appraisal systems within the practice. Often we delegate this to other members of staff, and it's certainly not part of traditional medical training. I actually saw this and thought, oh, that'd be handy, because I have something akin to being involved in the line management of lots of staff, and some training in how to do that would have been welcome in the past and would be welcome in the future. But you're right, some people won't be of this. I guess not all doctors need to be engaged in these activities. I'm thinking, not all doctors will be
Well,
required.
it kind of raises the question: is that if that's true? Because I think as we move forward with a larger multidisciplinary team, potentially neighborhood working and stuff, and the diversity that we're seeing in general practice, actually, we are seeing more that GPs are being asked to be kind of that consultant role with other clinicians working with / beneath them to provide that team structure for patient care.
Yeah, quite possibly. I guess that's not something specific to physician's assistants or these recommendations. I guess that's just a general evolution, and that sort of training would equip doctors to serve that role better. Some people may not want to take on those sorts of roles. I suspect there'll be other roles, available, or that might affect your career progression. But it's interesting, and if these roles are there, obviously doctors will need to interact with and work with, and a large part of that will be supervising physicians' assistants. So it doesn't just have implications for physicians' assistants; it has implications for the rest of the system, including doctors working with physicians' assistants.
Then the last two recommendations. One was talking about redesigning medical and multidisciplinary teams. So in particular, this is focused on the Department of Social Health and Care, talking about setting out multidisciplinary modes of working and what this will look like moving forward. And that they should focus on having a smaller group of experienced medical leaders and other professionals working together to create this kind of resource and things. And then safety reporting should be built into this, so effectively having a safety mechanism to report when there are challenges and problems, particularly for patient safety, and what does that look like as a system level. I mean, I kind of feel like stuff like that slightly exists, but I don't know couldn't quite understand whether they were recommending that we have a separate one just for physicians' assistants for that particular purpose, which kind of seems.
I mean, most reporting mechanisms on safety issues, identify the individuals involved for individual cases and the roles involved for thematic analysis. I think that's already good practice in general practice, but certainly in hospitals. So whether that's just providing clarity that we'll be needing to do those sorts of thematic analysis to look at sort of safety issues, or be able to extract the data so that we can look at and report on safety issues in physicians assistants. But it's unclear whether that would need a whole new system, or whether that's just advising people to make sure that their existing systems can comply with that new requirement to separate out and report up on that data. And will there be some national collection of that data for national analysis? It's unclear, but it's predictable to see that as a recommendation, I think.
And then it signs off by trying to indicate that how the recommendation will be implemented and stuff. But before we go into that in more detail, actually what I am going to do is we jump around a little bit in the document. So as you can see, the document is quite broad. I'm going to bring us down to a particular point. So when they looked at the analysis, they created various different points. So figure 6 was interesting, which was a timeline of events that surrounded the whole concept of physicians associates. So just to zoom into that, so you can see that a bit clearer on screen. There we go. So it talks about the first regulation notice here, the long-term workforce plan, which we covered a couple of years ago. Remember that one, Andy? Yeah. And then investigation to use of PAs and doctors' rotas. And those are the RCP EGM that some of people may remember, where it was quite contentious at the time in terms of the use of allowing the use of physicians associates and anaesthetic associates in healthcare. And then guidance that came through in terms of using physicians assistants, and then further guidance created by NHS England on the use of MAPS, and then it came through as the RCGP opposing the role for PAs in September 2024. And then the Leng review was announced in December 2024, and then further regulations, things had occurred. And then more recently, we've got the GMC course accreditation, which happened in May 25, and the court cases that started as a result of some of the safety incidents we saw from before as well. So a bit of a timeline, which I thought was just nice to share and reflect on. It then talks through the scope of the review, and in particular, I know Andy missed this point, but the principal question was, are the roles of physicians associates and anaesthetic associates safe and effective as members of a multidisciplinary team? And the supplementary questions, which was whether or not they should be discontinued, what modifications are needed, and should recruitment continue in these particular roles. So that's the scope, and it talks about that. When we looked at the evidence, which it covers here, it talks about the types of evidence. So it included
Gandhi,
reviews.
I missed the beginning. Were those questions answered at the beginning of the executive summary?
Yes, they were.
Can you just catch me up on
so the effectively they said that, so the question of should the role continue? Yes. Are there some adjustments that are needed? That's where the recommendations came through.
Yeah. Okay.
Yeah. Because I think they felt that there was not enough evidence to say that the role was not safe, and therefore the role should be discontinued. However, one of the key things that comes through in the evidence, which I'm trying to get to the table, it shows some of this. So various different parts of evidence, trial, paper reviews, forums, interviews, etc., and things. But here we go. It looks at some of the reviews and it compares the impact on PA roles and anaesthetic assistant roles compared to other roles in particular. So, for example, this one was with the safety of physicians associates in primary care, and it looks at some of the reviews, peer research and stuff, where in terms of it looks at consultation records, more likely to be appropriate. Safety of the consultation is slightly lower quality compared to GPs, but then when looking at things like number of X-rays ordered, no difference compared to AMPs, and slightly fewer compared to postgraduates and doctors in training. And similarly, in terms of what's this one? Prevention and fusion. I'm not quite sure. I didn't read this one in depth, so apologies. I don't quite know what that means. But then it talks about effectiveness of PAs, and there's more evidence that they looked at here in this particular table. And the general theme is that there's not really much difference between these roles and other roles. Okay, general theme. Obviously, there are some exceptions to that. So, for example, key ones to look at: the consultations were longer by PAs compared to GPs in Drennan. Fewer prescriptions compared to practices with PAs and without PAs in terms of the Senefit ones, and various other audits and reviews they looked at in terms of referral aspects. But generally, the theme that you can see here is just no difference in most of them. Yeah. It then talks about secondary care as well. I didn't spend as much focus, but again, it's generally no difference, or slightly lower, but within acceptable bounds is the commonality that you see here in terms of both safety. And then when it talks about effectiveness, we're going to go down a little bit more. As you can see, no difference seems to be the theme again in terms of compared to different roles, whether that's FY1s, FY2s, doctors, etc.
So Gandhi, it's interesting just to pull out some of the ones that aren't no difference. Was there one about patient admissions on page 46? Just interested. So admitted as inpatient, so increase. So is that just in terms of reading the table? So is that increased with PAs versus FY1s? Am I reading that correctly?
Yes, correct. Yeah. So that means that PAs had an increased number of patients admitted compared to FY1s. Yeah.
Okay.
Yeah. But generally speaking, it came through that it was not really much difference, albeit some extra changes. Because I didn't spend much time looking at anaesthetic associates, but then if we go down, it then comes to a comparison of the data, which I need to get to some graphs when I can find. Here we are. So these were graphs looking at, in particular, the perspectives of PAs versus doctors or other roles in terms of their capabilities in various different things. So if we look at this particular one, so this is comparing PAs in primary care and doctors in secondary care and their perceptions in terms of doing particular aspects. So in terms of taking histories from the first one, PAs thought they were 100% able to do that, whereas doctors in secondary care felt 50% where felt they were able to do that. This probably follows a trend that most people expect. So when it comes to some of the initial stuff, it's slightly higher percentages, absolutely for PAs throughout the board. So most things they felt they could do up until we get down to things like more complex stuff like antenatal care, ionizing or radiation prescribed medications, which, as we've already identified, a lot of these roles are not ideal to do that currently with the experience that they would have. But what's interesting is the hospital ones are considerably quite lower. I think many people would probably expect that to be the case. Apart from immunizations, which was a little bit higher than I thought it would be, at 56%. And when you compare that in the second table that came up, which is PAs in secondary care and doctors in secondary care, weirdly, immunizations were still relatively high again.
Interesting.
The other interesting difference is that when comparing the perspective of PAs in secondary care, the numbers by the doctors in secondary care were considerably lower. So generally speaking, these numbers are much lower compared to primary care. So I think there is a perception that the role is felt to be more safer in primary care by doctors in secondary care, which was a weird analysis I kind of came up with, and I don't know if that's the correct analysis. That was my initial pass-through look at the tables. Keen to know what people watching might be thinking, and Andy's musing over it as we go through.
Just help me understand the tables, Gandhi. So who are the respondents answering this question?
So the potential physician associates activities in secondary care given to response in the survey. So the survey was PAs in secondary care for this particular one and doctors in secondary care.
So is this asking PAs? So is the first graph the answer that PAs gave to the question about their ability to do certain tasks?
The various
and then
tasks,
the doctors that work with them were asked the same question about their ability?
Well, not necessarily working with them, but doctors working in secondary care.
That's my understanding. In that environment, not working with physicians. So they didn't have to be working with physicians' assistants in order to answer the question. Okay, so some of them won't have direct experience of it. It'll be perceptions. Okay, I think so. I understand now, but there's a big difference between the two. That's the take-home message.
Yep. And then
does that imply a real difference in capability, or is that, can we say that it is that rather than perception? It's asking perceptions, isn't it?
So that was looking at perception rather than effectiveness. I know one of the things that they mentioned repeatedly, they really struggled to evaluate effectiveness, particularly cost effectiveness for PAs and AAs in terms of how they work, because there's just no real way for them to evaluate that, which is a marker, I think, of the healthcare system in itself. It has no real ways of marking effectiveness of clinical roles, which is a bit of a weird place to be in 2025, I think. But
or those
came up.
Yeah, I mean, have they been able to conduct fresh research, or are they drawing on research that is out there already? Because you can evaluate effectiveness, but it's it involves quite a lot of audit work, I should think. So it might be quite expensive and time consuming to do those sorts of analyses, and they may not have been done.
Yeah, and one of the key things it does mention, most of the evidence they found in terms of cases and reports and stuff were pre-pandemic as well. So there is a delay in terms of that, in terms of the effectiveness, because obviously we are talking about a role that's had significant explosion post-pandemic, but a lot of the evidence taken for this report is only available pre-pandemic reports and things. It then talks about the various different aspects in terms of the considerations, which we've kind of already summarized. I'm going to skip most of this because then it does eventually get onto the recommendations in more detail, and it talks about the rationale for each of the recommendations. We've kind of talked a lot about the themes of this. I think what's an interesting one to look at is, let's go back to the table. Sorry, I jumped past it. This one. So this is the new kind of training scheme effectively for PAs. So newly qualified PAs Practice limited to specific roles and tasks based on initial training. And then 2 years post-qualification, eligible for initial role in primary care. Again, see the table, which we're going to have a look at in a second. And then after ongoing training and specific credentialing, they can become an advanced PA, so one band higher than what they're currently placed at, and then eligible to apply for a higher banding role if criteria and training experience are met. So career progression is quite becoming clearer. Yeah.
Gandhi, you may have already covered this, but what about physicians' assistants already working in primary care without 2 years experience in secondary care? Are they going to be grandfathered in? Do they have to go back and do those 2 years?
I could not find any information on this whatsoever. This is the problem. Yeah, I don't think it's mentioned that at all. So if somebody else has read this and found that information, I couldn't find that information in terms of trying to go through the document itself, which was frustrating, because I think that's a big question that does need to be answered. But maybe some of the stuff that is talked about in implementation will start to answer that. So this is now the key stuff. And more importantly, what I did like about this document, and we saw this in some of the ICB documents that we looked at recently, if you remember, it very clearly sets out who needs to do what. Okay. So Department of Health and Social Care, so immediately implement a name change from assistant to assistant from associate. So this becomes custom practice, and this will give clarity in terms of the role. Nominate a single responsible medical leader to take forward these recommendations in collaboration with the professions. Create a short-term working group to set out a vision for which the future services could be configured, and particularly the role will be utilised. Provide necessary resources to relevant colleges to develop new faculties for PAs and AAs. And consider whether there should be a dedicated fast-track training route for current course of PAs and AAs who may wish to retrain as doctors. And this may be the second news story that many people have read about today, which talks about the fact that these roles potentially can then be fast-tracked to become doctors for the existing cohort. So that's the only element I could find from that. Also, it doesn't talk about the costings and stuff. And unfortunately, I would probably imagine that we become postgraduates, so therefore apply with fees in terms of costings for those people if they were to go through it. Don't know. Unclear on that.
Yeah.
And then I'll finish this one off. Work with staff and employers and trade unions to explore these issues further and assure them that the current arrangements, including initial job bandings for PAs and AAs, are fair and appropriate. So look at what does that mean for the current PAs and AAs that are in these roles that are going to be impacted by some of these changes. Thoughts on the Department of Health roles?
It all sounds really, it all sounds sensible. And as you say, they're quite specific, recommendations. This is, broken down into a plan. It's truly an implementation plan, which is really welcome. It's sometimes absent from these sorts of documents and reviews. It's something that wasn't in the 10-year plan, for example.
There's more. No, there's more.
What's NHS England?
Yeah, NHS England. Yeah, NHS England gets some roles with this as well, despite the fact they've only got about a year left to go. Yeah. So take responsibility for the following: provide standard patient-facing information about the role of PAs disseminated through the NHS. So that's an interesting one, because it's quite a clear direction that actually NHS England is still responsible for the information sharing of this particular role. Create a distinct national mechanism for identifying PAs and AAs. So they've been tasked with that particular uniform challenge. Yeah. National audit on safety outcomes in operating theatres throughout HQIP for these particular roles and their use. Provide adequate local resource and expertise to deliver any change program related to PAs, and implement training for doctors on how to supervise other professions on the day. So NHS England's responsibility is to include this training, with also working with the Academy of Royal Colleges and leadership groups to make sure that that training is available to doctors to support these roles.
And other professions, it says as well. So not just physicians assistants. And I think actually that's something that that I would welcome. I've been in a position of supervising ARRS staff roles of various types, and it has been a little bit unclear. And particularly when I was a CD as well, we were concerned about the consistency of the supervision and support that other staff roles got from practice to practice, PCN to PCN. So some consistency on that would be welcome, and actually making NHS England responsible for providing the standards and the training is is welcome. Gandhi, can I ask a question? Again, you may not know the answer to this, but what's kind of the status of the Leng report in terms of whether those people asked to implement these tasks, do they have to do them? I mean, it's quite clear. It all sounds quite sensible. What's the kind of the status of the?
I don't think there's a legal requirement for them to do it. I think that they are simply recommendations for them to consider doing. Now, in particular, I guess NHS England, the question is whether they will have the scope and the capacity to look at these in the time that they're left available, and how much that will then transfer over to Department of Health and Social Care, as well as some of the other organisations, which we're going to talk about in a second. Just before we do, you asked about what happens to the existing PAs. This is probably the most relevant paragraph in the whole thing. So more experienced PAs should have their roles reviewed by their named supervisors to confirm whether they have the appropriate skills and training, and to modify their roles if necessary. This must not include seeing undifferentiated patients unless triage into adult patients with minor ailments, in line with the advice provided by the RCM and RCGP.
Okay.
Pretty crystal clear there, but I know that's creating more work for me. But
yeah, but we can grandfather in, as they say, some of these people in some of these roles.
The GMC has responsibilities when it comes to the actioning the change in name, as well as support for the Royal Colleges to make any necessary changes in curriculum, as well as change to the good medical practice guidance as well. Oversee standards of postgraduate training programs set out by the faculties themselves, and ensure that management training is built into the curricula of future generations as well. So it's giving it a lot more of the future roles. The Royal Colleges, it sets out about creating a faculty to support these roles, both for specifically the anaesthetists, for the physicians, assistants in anaesthesia, and then the other Royal Colleges. It doesn't specify which one, but a challenge to the colleges themselves to make sure that they set up a faculty to support and create the relevant governance to support that. And then brief recommendation for the union. So unions and representative professional bodies will need to play an important role in supporting physician associates and anaesthetic associates through the changes. And then local healthcare organisations basically saying you need to read the guidance and have a look at it.
Gandhi, who currently acts as their union? Is it within? Is it one of the more general ones, like sort of Unison, or one of the the other people working in?
I'm not sure if they have a formal union. There is an organisation called UMAP, which I believe is trying to become or position itself as the union for physicians associates, or now as physician assistants. So whether they'll have to change their name. But I'm not sure whether they've got legal status of a union. I just generally don't know. Is the answer to that, I'm afraid.
No, just interesting question.
Just before we move on to our next topic, because I know we talked at length of this and keen to take on some of the comments from our viewers, because we've got a couple already. The last thing I will show you is this, Appendix 5. So we always say the appendix is where some of the best information is. This is probably the most relevant one. So if you are a practice that has a physician's associate already working with you, if you're still thinking of looking at having physician's assistants in practice, there is a template job description provided in this guidance. Now, it's the first time I've seen something this detailed being offered by recommendations. I know that obviously NHS England do provide job descriptions for the R's roles, so it'll be interesting to see whether this now gets used as the adaptation for these roles moving forward. It's pretty clear, to be honest.
Yeah, it's
reasonable.
Yeah, just skimming through. And you're right, this is similar to the sorts of role descriptions that are in the PCN. There's probably more detailed.
But yeah, that is then provided for you from there. And then the rest of it is various other things in terms of references, etc. and stuff. Now, we've got some comments. So I'm going to spring on Simone's first of all. So UMAPS is a registered trade union. Thank you for that information, Simone. Wasn't aware of that. Yeah. And then Anish K. Patel. The whole thing is still a mess, especially in primary care, with RCGP saying PAs have no roles in general practice. Would practice still hire PAs? And I think that's the key question that we will now start to see. So you're right. Following the release of the Leng review, the RCGP have recommitted their guidance that PAs have no role in general practice, and that they're not recommending any new PAs taken on by practices. However, they have provided guidance that explains, as we saw in this document and we mentioned earlier, in terms of their current use in general practice, albeit I do still feel that guidance still is in existence for newly qualified PAs and doesn't take into account those that have been working for several years, potentially in practice as it is.
Yeah. Do you think the RCGP will? I mean, they're asked in this document to consider setting up a faculty within them for to support physicians' assistants. It may be that they re-look at that in the future, in having digested the Leng report. What do you think?
There may still be a little bit of a bum fight on this, I think, because don't forget, physician assistants can work both in general practice and secondary care. So I think there's still going to be this interesting discussion between primary, so the RCGP and the RCP potentially, in terms of who is the faculty for physicians assistants, compared to the physician assistants working in anaesthesia, is clearly going to have to be the Royal College for anaesthetists.
Well, we will see.
It's
a good question, though. I think people will perhaps still be cautious at the moment while they see how this lands and what happens as the recommendations are put into effect.
So I know loads of you joining us. We've got now 78 of you joining us live, and that's great news to hear. But we've got some other news stories that we're just going to cover very briefly. So we were talking about the RCGP. I think it's very apt that we then talk about this news story, which is that we've just been announced the newly elected chair for the next chair for the RCGP, which is Dr. Victoria Georgia Brown. So some of the people may know that Victoria was previously working in an officer role capacity a couple of years back, I believe, as the honorary secretary or joint honorary secretary, and she'll be taking over from our current chair, Camilla Hawthorne, I believe, in November time, which will be after the RCGP conference, and take on a 3-year term from that particular point. So an interesting position in terms of, I think, a well-respected individual take on the role. From what I've heard from a lot of the comments going around in terms of, you know, a new direction for the college potentially. But yeah, I guess news story to share with everyone. Thoughts on that?
Yeah,
Andy?
yeah. Welcome, Victoria. I don't know a lot about Victoria. You and you may not know much more, but I just wondered, does she have any particular interest or direction or sort of style differences or uniqueness compared to what we might have seen before?
So, as I mentioned, most of my experience was when I was on the council, and at that time she was the ONSEC, so very much have a clear governance head in terms of, and that's what the role of ONSEC very much had. And I think, from my understanding, since leaving the council, I mean, I've come across Victoria multiple times. You know, colleague, I'd consider, you know, a friend as well. And you know, very much I believe helped lead on a lot of the RCGP's perspective on physicians associates, for example. And I think, you know, many people will see as a you know, welcome election to that particular role. So remembering that the role of chair is elected by council, not by members. So this would have been via hustings. I don't know who the other candidates were. I know other candidates have been nominated to other roles. So I believe there's a new vice chair for member services, which is Jamie. Oh gosh, mind blob. I've forgotten his surname now. We know him.
I can picture him actually.
Birmingham faculty.
Haynes, something like that.
Jamie Haynes. That's it. Yes.
Jamie Haynes.
I can't believe I forgot that. Yes. So, and I think there's a third appointment which I can't remember off the top of my head now. I'm sorry, it's too late.
Artful Doctor. So that's the Artful Doctor on Twitter.
That is the Artful Doctor.
No,
yes.
Yeah, at the Artful Doctor. Yeah. No, yeah. Jamie's been fantastic at Midlands faculty, and within the RCGP for years. Okay, that's good. The chair often has quite varying levels of profile in interactions of the profession with the Department of Health, NHS England, and government. And we've had examples. I remember Jeremy Hunt at the RCGP headquarters with, who was it at the time?
Claire Gerardo?
No, it was Helen Stokes Lampard, I think. So
I think he had both, but yes, potentially.
I think, yeah. So you know, there can be quite a position of influence politically as well, although the
Mhm.
BMA do most of the contract negotiations. RCGP still has some sway, so it's quite a significant position. So hopefully she'll be able to have the impact that that she wants and that supports the
Mhm.
profession.
Mhm. And then I guess just to cover some more news stories, just as we try and tie off, because I think there's we'll probably spend a little bit longer on the um, Leng review than anticipated. So, key news story that came out today, which was West Streeting saying that they're not going to replace GP partnerships that are working well. I love the way that it canons that with working well, and there's no
Okay.
quantification of what working well possibly looks like. But this is obviously in response to the fact that there are two new GP contract mechanisms as part of the 10-year plan that we talked about the weekend in terms of the
Mm.
single neighbourhood partnership contract and the multi-neighbourhood partnership contract. And he was specifically asked this at an event today, which then obviously he's commented on that there's no intention to get rid of GP contract partnerships that are working well, again, to use those words. Thoughts on that, Andy?
I think it's really interesting. So when we were talking about the 10-year plan, I think we had reached the conclusion that it appeared to be sort of contract and model agnostic, that they wanted
Mm-hmm.
good quality general practice services, but seemed neutral in terms of how they were delivered. And if that's by the partnership model, they were supportive of that. There was description within certainly the multi-neighborhood provider contract that would have a role in supporting and supporting practices experiencing financial and I think they said performance or delivery difficulties, um,
Mm-hmm.
with I think it's coaching, mentoring, support, and I think it said even taking on their role or taking on those contracts where necessary. So I think they were discussing and introducing a different way of GP services being delivered, and many had interpreted that as a threat to traditional general practice. And I guess this comment doesn't really reassure people who
Mm-hmm.
perceive that as a threat to the partnership model or the traditional contracting model. So very interesting.
It is, and I think I'd agree that it hasn't really reassured the profession, even more so when you look at the next news story, which was that the GPs could potentially be back in dispute with the government over this. So, as of today, it was the GPC meeting, and they had invited Stephen Kinnock, who's the I forget his official title, but he's basically the MP in charge of primary care
Yeah.
specifically, and very much commenting that unless there is significant response and change taken, that the profession is recommending we potentially look at collective action or similar actions towards that, going into dispute. I think this is absolutely in congruence to the current resident
Mm.
doctors going on strike, with a planned strike for next week, I believe it is. So just remember that is next week, in terms of going ahead. So, part of the promotion for this particular episode, I mentioned we're looking at potential strikes, and I think this is possibly some signalling towards that being the case for general practice. So much so that I believe that a motion was put through at the GPC meeting, which is mentioned here and covered by our friends at Pulse and things in terms of what they were recommending. And the key one on here was where's it gone? GPC to develop a list of non-negotiable demands, which should include at least a £50 per patient increase into the core in the return to core. That's fairly strong comments there.
That's quite a lot, isn't it? So the GMS is currently sort of 120, 22, 23 per patient. So £50 is quite an increase into core, if that's what it's
Although
asking.
many comments do and many analyses do show that if the core contract had kept in line with actual inflation, that's what we would be looking at.
Well, there you go.
Mm-hmm. So yeah, definitely strong potential words from the GPC in terms of directed towards West Streeting, Steve Kinnock, in terms of particularly some of these announcements that we've had more recently. And I think it'll be interesting to see how they respond over the coming week or so in terms of some of that aspects, as well as what does this mean for the profession. One final quick news story that we've got, which is probably slightly tech relevant, hence why I'm going to cover it, is GPs to check 57,000 patient records for vaccination errors following an IT issue. So interestingly, this is not EMIS for once. We've talked often about some of the challenges with the system providers, and this is not them. Do you know who this might be, Andy? I know you've not read the story.
I've not read the story. No, I've hot-footed it from another engagement that went on longer. So apologies for appearing a little less prepared than normal today. I mean, it's on the screen, Gandhi, so I think it's AccuRx.
It is, which is a bit of a surprise because AccuRx very much have been seen as, a key innovator and supporter of general practice of many practices and continue to be so. But effectively, this looks like that there was a miscoding aspect that put through in terms of their mass messaging system, so their AccuRx batch messaging that they have. And as a result of that, an incorrect code was allocated to the messages that went out, subsequently meaning that patients were documented to have been given their vaccinations rather than inviting them in for their vaccinations. And unfortunately, this does potentially then mean some significant work that perhaps we'll have to do in terms of reevaluating those patients, coding those records correctly so then the subsequent invites and stuff do continue to work properly. Bit of a nightmare.
Yeah. Hopefully there's some sort of quick kind of automated way of doing these searches and batch replacing the codes, but
fingers crossed it should be, but still extra work. And you and I both know about that with some of the recent challenges we've been having locally with pathology systems and various other IT systems that exist currently. So yes, can absolutely understand the frustrations that can cause, because it potentially then takes people away from doing face-to-face core work in general practice as a result of that, because the extra workload coming through as a result. We've talked about some serious and significant things in the past hour or so. So just to recap, the Leng review is finally out. Many people have been waiting for this in terms of the future of physicians associates, now called physicians assistants. And the recommendations from this are fairly clear in terms of what they're recommending, with plans for implementation and delivery. The interesting part will be see how this works moving forward from organisations like Department of Health, NHS England, and practices that employ these roles, as well as obviously the trust that do so in terms of physician assistants, and now called physicians assistants in anaesthesia. We also then talked about the fact we've got a new chair elected for the RCGP to take over in November. So Dr. Victoria Churchill-Brown, who's going to be taking over from Professor Camilla Hawthorne. And then in addition to that, the potential for strikes coming through, with planned strikes already due from residence doctors next week, as well as the possibility the GPC may call for action in response to the 10-year plan. And obviously within that has been Wes Streeting's comments that he does feel that there's still a place for general practice partnerships, but those that are working well. Finally, an IT story about miscoding of fluid blades. Sorry, my voice is going.
Miscoding of vaccination invitations as vaccinations given by AccuRx. I think it said affecting up to 47 or 57,000
patients
records. So quite a significant data error.
Yep, and I guess that must have been the news story that you're all keen to hear on, because that's the one that's pushed us over 100 live viewers. It's great to have you all here with us today. However, we're going to now sign off. If you want to join us in a couple of weeks' time, myself and Andy will be back live talking about all the news updates and everything that's going on in general practice. Alternatively, you can join myself in a couple of weeks' time on the 30th of July as I talk to TPP about some of the AI tools that they've got. That's following our absolutely stonking live stream that we did just yesterday with 300 live viewers taking part. So definitely stuff that you guys want to hear. We've got loads of content coming up for you. And as always, we'll be here to take hands to your primary care and learning. And we'll catch you in the next episode. Join us.